Chair recognizes Mr. Perry from Pennsylvania.
Thank you, Mr. Chairman. Gentlemen, thank you for being here. The average life expectancy for Americans is 78 years, despite spending more than every other Western developed country, which has a life expectancy of 82 years. So we're not doing so well. 6 in 10 Americans have at least one chronic disease, with more than 40% of children suffering from at least one health condition. I think that's astounding. Mr. Safdar, as of March 31st of this year, the American Society of Health System Pharmacists lists 238 drugs in shortage. These shortages include pharmaceuticals used to treat infections, heart failure, psychiatric conditions, and cancer, and include drugs such as amoxicillin, penicillin, cisplatin, and active ingredients in most chemotherapeutic regimes. As you probably know, the medications taken by Americans are manufactured largely overseas, and their active ingredients are overwhelmingly made in India and China. Can you explain to us how our dependence on foreign pharmaceuticals markets has created manufacturing delays for critical medications across the USA?
Thank you, Congressman, for the question. While I am not an expert in the inspection of foreign facilities, it is clear that our supply chain is global at this moment, and medicines come and the ingredients come from all over the place. We are usually very pleased to see efforts to secure the supply chain and to secure manufacturing facilities with inspectors from the FDA. And it's part of what makes our supply chain most resilient.
Do you think it's a good plan for the United States to rely so heavily on other countries, including ones that consider us their enemy, which would be the Communist Party of China?
Well, the national security implications of that are definitely outside my expertise, but I think that the doctor here has probably got a better perspective.
Okay, Dr. Kessler, what do you got?
I agree with you 100%. I mean, I was in charge of, with my colleagues, Operation Warp Speed of sourcing, right? For the monoclonal antibodies, for example. We are at risk as a country. We are not producing in this country essential medicines for life-saving conditions. We need to do a better job.
So either one of you or anybody, is it because the precursors or the drugs themselves are rare and unattainable in the United States of America?
If you look at the top universities for chemistry today, Nature Index have 10 out of 10 are in China.
But is that because they're unavailable in the United States of America?
You need chemists make the drug, right? Where are they training the chemists? Where is that scientific expertise? Right? We're not investing in this country in the natural sciences.
So you're saying we have the material, we don't have the know-how. Is that what you're saying?
We don't have the know-how, we don't have the plants, we don't have the commitment.
Do these drug shortages then enhance the proliferation of illegal knockoff drugs? Is that a cause and effect relationship? We can't get them here, so there are knockoffs produced overseas, even in our country, that are often dangerous to people in our society that think they're taking a legitimate drug. They get it on the internet or get it through the mail and then take it and then overdose. Is that a part and parcel to this?
It's a much better strategy, right, to have the talent, the expertise, and the commitment, and have those chemicals come from a secure supply chain, right, than through a lot of different unregulated sources. I mean, you want to lose sleep? That's what you should lose sleep about, where our medicines are coming from.
Mr. Safdar, does the presence of a strong domestic compounding industry contribute to supply chain resilience and patient access at any time, but certainly during national emergencies or supply chain disruptions?
Congressman, thank you for the question. Yes, as I said in my opening remarks, I think that there is a critical niche role that compounding plays in our drug supply. But as the FDA has said, compounded medications are not approved and they're not tested for safety or efficacy, so they should be used as a last resort. But as you pointed out, if there is a medicine you need for treatment that would be dangerous to your health to delay, you should definitely take the compounded version if the normal product, the FDA-approved
But
product,
what
is
you
not
say
available.
seems to imply that there's somehow danger, and aren't they manufactured domestically in licensed facility with oversight of state boards?
The FDA has actually been very clear that their safety is not the same as FDA-approved drugs, which would be generics or the branded products, that they take a second tier to safety. They're not to be used as a first line of treatment. And that's one of the problems we're seeing, is that we're seeing upstart and unknown and somewhat shady telehealth companies.
You're not conflating compounded drugs made in a facility, in a licensed facility under state monitoring or oversight with illicit counterfeit drugs, are you? You're not conflating the two, are you?
That's a whole nother problem.
Okay.
There's three types of danger that we've seen in the GLP-1 space. But even a medicine made in a state board of pharmacy or FDA-inspected 503B, for example, outsourcing facility, is not an FDA-approved drug. The FDA has given it a status of being not approved and not tested for safety or efficacy. Now, would I take it if it was that or skip my cancer treatment? I would absolutely take it. But it's not supposed to be the first-line product. You don't start treatment on it.
I understand. Thank you, Mr. Chairman. I yield.
But before I recognize Ms. Brown, I have